Hello and good evening, everyone. Welcome to our 72nd Blue Hills Virtual Seminar. So, Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. This platform is brought to you by Blue Hills Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Tadala, a general physician and first aid trainer from Blue Hills, Ethiopia. Today, it's a pleasure to have Dr. Mathias Negussie here with us to present on the topic liver analgesia. Dr. Mathias Negussie is an assistant professor of anesthesia and critical care and pain medicine at St. Paul Hospital.
Dr. Mathias, I'm anesthesiologist, critical care and pain medicine specialist. So today I'm here to discuss about liver analgesia, which is very common in the very problem here in our society. So I will go through liver analgesia as fast as possible due to the as an objective. At the end of this session, the participants are able to at least define what's pain in the liver analgesia, what is to understand some anatomy of the liver pain and its effect on the mother as well as the fetus, apply some pharmacologic and non-pharmacologic liver pain management. So, and know some of the basics principles of regional analgesia for liver pain. So what is pain? So we'll pass to the definition as the International Association for Study of Pain defines pain as an unpleasant sensory and emotional experience which is actually associated with actual or potential tissue damage or described in terms of such damage. So it has two parts, as you can see. There are sensory part as well as there is emotional or affective part. So there is objective sensory or tissue damage as well as there are also emotional and psychological components when we define pain. So what's liver analgesia? It refers to administration of any pain relieving techniques or medications during liver to provide relief from liver pain, and its aim is to minimize or, if possible, eliminate pain during daily laboring or during birthing process. Okay, so the purpose is, as generally, it's to relieve pain, to promote relaxation during delivery, to facilitate progress of labor. A mother who have no pain, the labor progress it's said to be facilitated. Previously, some of the previous thinking was maternal bond will increase if there is a mother feels or the mother gives birth through pain. But the current one is pain in mother do not need pain. That will, even if the patient is managed with the pain, or if the mother is managed with the pain, so the maternal bond with the baby or the neonate is increased. Currently, the recommendation that so liver pain, as you can see, it's very painful. Notoriously, it's very painful, and it's more common in nulliparous mothers than multiparous mothers. So it is very painful. It is said to be a broke or a digit amputation without anesthesia. It's at the level of a digit amputation without anesthesia. So nulliparous mothers are more feels pain than the multiparous mothers. As you can see, the McGill's functional pain score. This one was done with those physicians called with McGill, and they prepared a questionnaire, and it's recorded as this one. So it's pain is more more the nulliparous ones feel more pain, and in between the nulliparous, if the nulliparous mothers prepared for childbirth, they may have lesser pain if we prepare them during childbirth training, or they may have decreased pain threshold during this if they are prepared during their pregnancy. And the multiparous mothers, as you can see, they have lesser pain threshold than the more pain threshold than the mothers with multiparous. Okay. So coming to the anatomy, when do the mothers feel pain during their labor? The first stage of labor is the most common. And during the first stage of labor, the pain results due to uterine contraction, and which is associated with dilatation of the cervix as well as the stretching of the lower uterine segment. So this is during the first stage of labor. So in this time, usually the labor it's excruciating, and it's a piercing type of pain, which is usually transmitted with afferent nerve fibers, C fibers. So it's referred to the level of T10 to TL1. Usually it's said to be during the latent first stage of labor. It's around T11 to T12, but later on the active phase of the first stage of labor, it will include the T10 to L1. So you have to know these labels so that you can ameliorate or to treat pain during this labor. So it can be done with paracervical block, paravertebral block, lumbar sympathectomy with epidural, or spinal anesthesia or analgesia can be done in this label. So paracervical is currently not advocated, but paravertebral blocks, lumbar blocks, or with epidural and spinal blockage can be a possibility, but still you can use other systemic opioids and other non-pharmacologic methods can also be used. But the most important and the most best one is to block with this regional blocking agent. So at the second stage of labor, pain comes from it results from the engagement of the fetus from the to the level of the perineum. So it results in distension of the vagina vault, perineum, and this pain are carried by the nerve fibers from sacral nerve fibers from S2 to S4. So in this level of or during the second stage of labor, we have to include the first stage of labor with S2, S4, which means you can extend from T10 to S4. So analgesia can be includes the first stage of labor plus pudendal nerve block can also be used, or extension of the epidural blockade to the level of T10 to S4 is important. So maybe in between my slides are making me difficulties with stacking. So I think so as you can see from the anatomy, so these are the places you have to block, the paracervical block, which is not recently advocated, but pudendal block and the different epidural and the paravertebral blocks can be done here. So, so with this, what is the problem with pain, or what is the effect of pain on the mother as well as the fetus? So during labor, if there is a pain and the stress, there are an increase in sympathetic stimulation. The patient will have tachycardia, tachypnea, hypertension, hyperventilation. So this all will result in different effect on the mother and the fetus. So the general outcome is the fetal metabolic acidosis and fetal hypoxia is the end result with pain during the mother during labor. So we will see specific systems. On cardiovascular system, as you can see, increase in oxygen demand of myocardium because increase in sympathetic nervous system, or during labor there is an increase in this sympathetic system, so heart rate will increase, so the patient's myocardium will require or demand more oxygen. At the same time, due to this tachycardia, there is also less time to oxygenate the myocardium, so there is a difference in oxygen delivery. So all this results in an effect on the cardiovascular system. So especially patients with cardiovascular disease, or those with MI or stenotic or severe stenotic lesions or different cardiovascular problems will not tolerate this pain during pregnancy or during labor. Okay, so altogether they result in decrease in placental perfusion, and at the end stage is a fetal effect on the fetus. Okay, so effective neuralgial analgesia provided by epidural local anesthetics or intrathecal opioid administration significantly reduce 50% of maternal catecholamine concentrations. So, which means patient, specialist patient, as I said, patient with cardiovascular problems or disease will not tolerate this pain during labor. So, adding neuralgial blockade or neuralgial analgesia for those patients will significantly decrease the catecholamine concentration and the effect of the load on the cardiovascular system. Okay. So you see the respiratory system, you can see there is tachypnea, there is a decrease in tidal volume, diaphragmatic splinting, inability to cough. All those will result in secondary effect on the lung, which will result in pneumonia, lung collapse, pulmonary embolism, reduced oxygen supply to the tissue. So, still treatment of labor pain with epidural analgesia will minimize the increase in the net unit ventilation and the accompanying increase in oxygen consumption. Okay, so the other effect is on the gastrointestinal system. It will result in ileus, delayed gastric emptying, nausea and vomiting, constipation and urinary retention. So this all, especially patients if the mothers will end up in CS, so this all will result in difficulty during airway management, which will result in aspiration and different complications. So pain management is also very important. So the other very important thing is the psychological effect on the mother. There is anxiety, which is followed by anger, resentment, negative relationship with the physician, the nurses, even with the baby, the delivered baby will also, the bond will be decreased, the bond between the mother and the baby will decrease, as well as the next pregnancy, the psychological effect to the next pregnancy is also affected. And there are also some reports that says it will progress to chronic pain. So these are all the psychological effect on the patient. So you have to treat pain. So how maybe just to involve our audience, how are you managing pain in your patients who are laboring in your setup? So you will have options, non-pharmacologic options, systemic medication options, and regional analgesia are some of the options to treat pain during labor. Okay. So previously there are inhalational analgesia, conventional spinal analgesia, or paracervical blockade were used, but currently they are almost outdated. There is nobody using inhalational anesthetics, and the spinal analgesia is also not usually used once we have epidural analgesia. So paracervical blockade is also not commonly used due to the close proximity with the uterine artery, and that will result in vasoconstriction of the uterine artery, which will result in uterine placental insufficiency and effect on the fetus with acid-base derangement. So it's not recommended. Those the above three are the recommended ones, but still the non-pharmacologic ones are not well studied, but we will see some of them grossly. As you can see, there are two categories: with those with minimal training or equipment, or those with specialized training or equipment. So, with those with, as you can see, emotional support, touch and massage, we all are doing this during our when we are attending the labor. You usually emotionally support the patient, especially if it was better if the patient's husband or if the patient's more close friends will support emotionally. That will decrease significantly a pain, but it's not well studied. But still, some of the people recommend touching the massage as well, as you can remember from your previous labor pain, labor attending labor. You can massage patients with your patients some on the back, on the leg. Some of them will ask you to massage them. So it will decrease the pain, but not still not well studied and not at the level of the pharmacologic one. So all patients should require pharmacologic or vaginal blockage. So you can, those things are not well supported, but still they will help in managing pain. So we'll pass to the childbirth preparation, which is very important during pregnancy, during the AMC follow-up. You have to prepare patients or mothers who are going to have labor in the near future. So the goal is to educate the patient, the pregnant mother, about the labor and about the delivery. There are relaxation training, there are breathing techniques that are given to the mother as well as to the supporting person, either the husband or the friend, a close friend, a close family can also be a trainer. So this can be given with trained person. So the breathing technique, it's easy. So you can tell the mother to breathe deep during the start of the labor and shallow in the fast breathing during between the contractions. Okay, between the uterine contraction, the mother should have needs to breathe shallow and fast. Then once the contraction is gone, then the patient will start to breathe normally. But at the start of the contraction, breathe deep, then frequent fast and shallow breathing between the contraction is the recommended one, and it will significantly decrease pain. Okay? So the benefits are multiple, with greater maternal control and cooperation, with decreased maternal anxiety, and it will reduce maternal pain, decrease maternal need for analgesia and anesthesia, because those anesthesia or so analgesia, pharmacologic analgesia especially, will have significant side effects. So it will decrease this side effects. So it will shorter, it's said to be decrease laboring time, as well as diminish maternal morbidity, less fetal stress, and it will strengthen the family relationship. So coming to the systemic opioids or pharmacologic part, the most commonly used ones are parenteral opioid analgesia. Opioids are most widely used due to different reasons. Opioids are usually agonists at the opioid receptor. There are natural opioid receptors in our body, which are called as endorphin, enkephalin. These are natural opioids. So these opioids, the synthetic opioids, will agonist. They are agonists to those natural opioids. So their popularity is due to their low cost, ease of use, and lack of need for specialized equipment and personnel. So they don't need any specialized person, or they don't need any specialized equipment. They are easily available and low cost. So we tend to use opioid frequently and widely. So it is said to be we'll see the systemic opioid management or pharmacologic management of liver analgesia. One of the most common is parenteral opioid analgesia. So opioids are widely used, and generally the mechanism of action is it's agonist at the opioid receptors, the natural opioid receptors in our body, such as endorphin or enkephalin are the natural opioid receptors. So these opioids are synthetic opioids. So they are usually agonists for those opioids. So opioids are very popular all over the world. This is because due to low cost, they are easy to use, and they don't need specialized equipments or a specialized person to use it. So they are easily accessible as well as easy to use. So, but the problem with opioid is that parturients usually commonly report a dissociation from the reality rather than complete analgesia. Okay. So, as I say, opioids are usually have a problem, a side effect with the mother as well as with the fetus. So, the mother will usually experience nausea, vomiting, delayed gastric emptying, dysphoria, and drowsiness. Especially hypoventilation is also common on those mothers. So, there are also potential side effects on neonates as well as the fetus. Okay, so the efficacy of systemic opioid analgesia and the incidence of side effects are largely dose dependent. So there is no one better than the others, but majority the problem depends on the dose. As you increase the dose, the problems will arise or the side effects will increase. So it is more of dose dependent. So all opioids they easily or readily cross the placenta. It is due to high lipid solubility and the low molecular weight of the opioids. So once they cross the placenta, they will have effect on the neonate or the fetus, will result in respiratory depression. And once the patient or the neonate is delivered, they will have respiratory depression or neurobehavioral change. This is where they are delivered within the or within the time limit of the opioids. Once you give opioids, then you have to wait until the opioids are clearly eliminated from the body before delivering the neonates. Okay. They may also affect the fetus in the utero. They will result in decrease in the variability of the fetal heart rate. So opioids have side effects depending on the dose and sometimes on the types of the opioids. Okay, so as I say, the neonatal respiratory depression depends on the dose and the timing of opioid administration. Okay, for example, the mother is going to deliver the fetus within the next 1 hour, and if you give morphine for this mother, then there is definitely a neonate will have respiratory depression. So because the morphine's elimination half-life is more than 1 hour. Okay. So lumbar epidural analgesia was associated with improved neonatal acid-base status and compared to the opioid analgesias. Okay. So opioids can be given on different type. Either you can give them intermittent bolus or in continuous drip or in patient-controlled analgesia. Okay, so when we see the intermittent bolus parenteral opioid analgesia, you can give them with subcutaneous, intramuscular, or IV injections. So the route and timing of administration influence the maternal uptake and the placental transfer. So IV administration is generally the preferred one because of different advantages. Okay, the one you can have onset of analgesia is fast with IV administration, and the timing and the magnitude of the peak plasma concentration of the drug are predictable. When you give them IM or subcutaneous, you can't predict at which level it will be cleared from the plasma. So if it's given IV, then it's easy to predict the plasma concentration. The other one is you can titrate easily. Titrate at the desired effect can be easily titrable if you are giving them with IV. Okay. So coming to specific opioids, you can see morphine. Morphine is the most early or the oldest opioid, and it was called morphium, which is god of dreams, Greek word. And the mechanism of action is morphine is has high affinity for mu opioid. There are different opioid receptors, mu, kappa, delta receptors are there. From that, opioid is a mu receptor, and its administration is only on two routes, IV and IM. So the dosage is different, as well as the duration of action is also different. As you can see, with IV administration, you have 4 hours of action of morphine, but in case of IM, it's 4 to 6 because we don't have predict. As I said earlier, with IV you can predict the time, but with IM or with subcutaneous, you can't predict. So that's why we say usually 4 to 6. It depends on the patient's metabolism. So metabolism of morphine usually has 2 morphine metabolites. 70% is morphine 3 glucuronide, which is not active, but morphine 6 glucuronide is the active one, and it's also more potent than the mother morphine, around 13 times more potent than the mother morphine. The same analgesic effect as well. Okay, it is usually eliminated with the kidney. If there is renal derangement or renal function test is deranged, it will take more time to eliminate morphine, more than 4.5 hours, which means the complication is also will increase with patients with renal derangement. Okay, so morphine usually crosses placenta within 5 minutes, and it will have adverse effect to the mother as well as to the fetus. Okay, it's usually more side effect to the mother than the fetus. It will have respiratory depression, hypotension, rash, pruritus, and sedation and dysphoria. These all are a complication of or side effects of morphine. But to the fetus, if the fetus delivered within 4 hours of IV or 6 hours of IM, then the patient may have, the fetus may have respiratory depression. Okay, you have to consider those things. The other commonest drug is meperidine or petidine, which is usually called, and its the mechanism of action is a mu and the kappa opioid receptor agonist, and it's said to be 10% of the analgesic potency of morphine, or morphine is more stronger than meperidine, or meperidine is only 10% of the morphine. So it's usually given in IM for 15 to 100 milligram can be given to the an average of 70 or 60 to 70 kilogram of mother, but it depends on your patient. Okay, so the duration of action is almost 4 hours, but it is not predictable. It's 4 to 6 hours, and the onset of analgesia may be 10 to 15 minutes, but 45 minutes may be required to have a maximum effect or the peak effect. Okay, so the duration of action it may be 2 to 3 hours. Some says 4 hours, but the minimum is 3 hours. So patients or mothers should not deliver within 3 hours of giving petidine. Okay, it's highly lipid soluble and across the placenta within 6 minutes, and it will be metabolized in the liver to normeperidine. Still, it's an active form of meperidine or petidine, and it will have effect on the neonates. So neonatal effect is or maternal administration of meperidine may reduce the fetal aortic blood flow fetal muscle activity as well as fetal heart rate variability. So we have to consider those things. Okay. The adverse effect is more of to the neonates, as I have said. It will result in reduced duration of wakefulness, attentiveness, and breastfeeding. We will have lower Apgar score, we'll have lower muscle tone. But there are less effect on the mother, which will result in nausea, vomiting, and dysphoria, respiratory depression. But these are less in clinical scenario, or these patients may not develop those side effects. But the problem with petidine is the effect on the fetus. Okay. So the quality of liver analgesia produced by meperidine 50 milligram is comparable to the intravenous acetaminophen or paracetamol. So with side effect 64% versus 0%. So if you get acetaminophen or paracetamol 1000 milligram, if you compare it with meperidine or petidine of 50 milligram, then the better one is acetaminophen. I will go for acetaminophen because there is definitely zero side effect or problem with the fetus as well as the mother, but analgesic effect is, or analgesic potency is almost equal. Okay, so it's better to use currently the recommended one rather than using petidine is IV acetaminophen. The problem is cost-wise. Cost-wise, they are not comparable because petidine may be easily available. Acetaminophen is not easily available. So meperidine is the most common opioid given for liver analgesia worldwide, and this is most likely due to the result of easy administration, availability, and the low cost. Okay. The other drug currently recommended is the fentanyl. Fentanyl is a synthetic opioid which is highly lipid soluble, protein bound, and selective mu agonist. So its potency is very strong. It's 100 times that of morphine and 800 times that of meperidine. And it is usually selected for liver analgesia due to its rapid onset. The peak effect will rise within 2 to 4 minutes, and the duration of action is maximum of 1 hour. Okay, this is a beneficial effect. Okay, because within 1 hour, if the patient is going to deliver, then there is no effect on the fetus. Even if within 1 hour deliver, if the mother delivers within 1 hour, still there is no significant or clinically concerning effect on the fetus. So, because this is due to lack of active metabolites, fentanyl is metabolized to inactive form almost 100%. So it is not a problem. So currently the recommended liver analgesia for laboring mother is fentanyl. Okay, it is administered with IV, IM, sublingual, intranasal, and the effect is almost similar, but IV one is a preferred one. Okay. So small dose or single dose will go rapid redistribution and there is no problem with, but when it is large dose or repeated dose, it will accumulate in the fat and slowly will release to the active or into the brain in the different areas. So single dose is not a problem. Still, accumulated doses are not such an effect compared to the petidine and morphine. Okay. So as I said, it will go under liver metabolism into inactive form and excreted in the urine. And fentanyl is, since it is highly lipophilic, it will cross the placenta rapidly within 1 minute. But there is no clinical significant adverse event to the mother as well as to the neonate. Okay. So the other one is a tramadol, which is atypical, weak, and synthetic opioid. It has all affinity for all opioid receptors. That's why the complication or the side effects of tramadol is increased, and it will be administered orally, IV or IM, with a dose of 15 to 100 milligram every 4 to 6 hours. Okay? So the analgesic potency is equal to meperidine, but the side effects are almost higher than the PTD. The onset of analgesia is within 10 minutes of IM administration with effective duration of 2 to 4 hours. It will stay for at most 4 hours, at minimum 2 hours. Because it is an IM, we don't usually accurately predict the plasma concentration. Okay, so it is metabolized by demethylation on the glucuronidation in the liver to several metabolites. So that will result in different side effects. And it is excreted through the urine. They have prolonged half-life, elimination half-life, about 6 hours. If it is active, there are some active forms of tramadol, which is called M1. It will take longer duration in the plasma. Okay. Units have complete capacity to metabolize the active one, and it's not due to their liver immaturity. That may not be a problem for tramadol. Okay. So we'll have antagonists for those opioids, which is called naloxone. It will antagonize both at different sites of opioid receptors, but the majority of the affinity for mu receptor is greater. So it is a drug of choice to treat side effects, especially patients who receive overdose for opioid will be treated with naloxone. And it is usually given intravenously, subcutaneously, intramuscularly, or intratracheally is a possibility to administer naloxone. So the dosage is very minimal, and the peak effect is within 2 minutes, and the duration of action is maximum of 40 minutes. Okay, so you may require frequent dosage or continuous infusion may be required because the duration of action of some of the opioids are not equal to the antagonist. So we need to continue giving naloxone for those who have overdose or side effect of opioids. So the other is patient-controlled analgesia. As you have said, intermittent bolus opioid, then continuous drip, which is not currently recommended, and the third one is patient-controlled analgesia, PCA, which means the patient will control the given drug. Okay, so the advantage is yes, patient-controlled analgesia has superior pain relief with lower dose of drug and less risk of maternal respiratory depression compared with bolus administration. They have less placental transfer of the drug. They will have less need for antiemetic agents, greater patient satisfaction. So these are the benefits of patient-controlled analgesia. Patient-controlled analgesia means there are machines or computer, like a computer, you adjust those machines to the patient, and the patient just presses when he needs analgesia, or when the patient needs analgesia, or when the mother needs analgesia, they just press the press button, and it will deliver the required dose of analgesia. So it's easy. In other countries, they are using patient-controlled analgesia, and it's beneficial, but currently we are not practicing those way of administering analgesia. The other one is regional analgesia. So we'll see some of the regional anesthesia, especially the spinal analgesia, single shot, lumbar epidural, pudendal block, and the paracervical block. Pudendal block and the paracervical block are not discussed here. So we'll focus on the epidural analgesia, and so the others are almost similar to, especially spinal analgesia is almost similar to the epidural analgesia, but which is widely used currently is the epidural analgesia. So I will focus on the epidural analgesia. Okay, it is a part of neuralgial block, and it's widely used currently. in general operation, in general surgical anesthesia, with alone or with addition to general anesthesia. And it's currently the most preferred one for post-operative pain and obstetric or labor pain management. So to see grossly, you will see some of the anatomy of the vertebra. As you can see, we'll have vertebral canal with different structures, and we have ligaments, so which are specific to epidural insertion. We'll have, as you can see, from the skin subcutaneous tissue, you can see the spinous process. The spinous process are connected with supraspinous ligament. So we will pass through the supraspinous ligament, and between the two spinous process, you will have interspinous ligaments. So deep to the interspinous ligament, you will find the ligamentum flavum. So these are the structures we pass through during our insertion of epidural catheter or epidural needle. So I may not need to spend more time on this. So how do we identify the place we need to insert? There are surface landmarks. Some of you may be familiar with it. We'll have different level of surface landmarks. So the most commonly used for lumbar epidural is the level or the line between the iliac crustus. We draw or we imaginary lines that will connect the two iliac crustus, which will pass through the body of L4 or L4, L5 interspace. So we'll hold that surface landmark and we'll count up or down. So the other levels are, epidural can be done on every level from cervical to lumbar area. So you can have different level of surface landmarks, especially the C7 prominent is one. The other is the angle of scapulae. The lower angle of the scapulae will, if you draw the line between the two lower or inferior angle of scapulae, you will pass through the T7 body of the T7. So these are some of the landmarks. So we will use those landmarks. So there are indications to use epidural insertion. One of them is labor pain or labor analgesia. But the most important thing is the contraindications. For those who are not indicated to do epidural insertion in the epidural management. The first one is if the patient refuses to do take epidural, then that's absolute contraindication. Bacteremia, especially culture confirmed bacteremia, it is an absolute contraindication. Infection at the local site and at the level of your insertion, that's still an absolute contraindication. Hemorrhagic diathesis or anticoagulation, patients on anticoagulation like warfarin or it's only aspirin is also the only one which is okay with epidural insertion, but other anticoagulations are not indicated, or either we have to stop. If, for example, if a patient is taking warfarin, we have to stop at least 5 days ahead of insertion. And if the patient is taking heparin, unfractionated heparin, at least 6 hours, or low molecular weight heparin, at least 12 to 24 hours, the patient should need to discontinue those anticoagulations. So these are some of the absolute contraindication. Increased intracranial pressure still is an absolute contraindication due to the fear of herniation. So we don't usually recommend for patients with ICP. But for the therapeutic or treatment of ICP, still you are doing inserting epidural catheter so that you can drain the CSF through the one of the method of managing ICP is also inserting epidural and draining the CSF is also another way, but it should be indicated for the patient. The other related contraindications are sepsis, uncooperative patient. If the patient is uncooperative, like patient with psychiatric problems or patient with GCS, decreased GCS, those patients may be not cooperative, so you don't usually prefer to do. But that's the relative contraindication. If the benefit is higher than the contraindication, still you can use. So that is why we say relative contraindication. For example, stenotic valvular heart lesions, especially severe mitral stenosis, severe aortic stenosis. There are patients with pregnant mothers who come with severe stenotic lesions. For those patients, the insertion of epidural is more important than the contraindication. So titrated dose of epidural is important for those patients. So we usually recommend for those patients. So that's why we say it is a relative contraindication, not an absolute contraindication. Okay. So pre-procedure, we have to prepare our patient, we have to prepare our monitors, we have to prepare for emergency scenarios due to the complications. If the complication arise, we have to treat the complication. So we have to prepare monitors, especially the baseline monitors like pulse oximetry, ECG, and non-invasive blood pressure should be available. Medications for general anesthesia should be ready, and the patient aseptic technique for preparing for aseptic technique should be ready, and patient should be informed. We have to discuss with the patient. We have to discuss what procedure are we going to do. We have to discuss the complications, the acute complications, the late complication, as well as the fatal or rare but fatal complications should be discussed with the patient, and the patient should be given an options. If they refuse to use epidural, we have to tell them there is another option like systemic opioids, or different options will be informed to the patient. So we have to discuss and at least informed consent should be taken. And if possible, informed written consent should be taken for those patients. Okay. So positioning, as you can see, we have two ways of positioning, either sitting position or lateral position. But the most important, the most recommended for pregnant mother is the sitting ones, due to it will expose the interspinous process will be exposed easily in sitting position. So it is for delivering mother, it should be in the sitting position. So we'll have two ways of approach, usually the midline and the paramedian approach. The midline approach is the preferred one. Unless the patient is obese and difficult to find the anatomy, then paramedian may be the option. But usually the midline approach is preferred one. Okay. What are the equipments? The equipment is usually we'll have epidural kit, which will be filled with different equipments. Epidural needle, as you can see, the epidural needle with epidural loss of resistance needle. So the equipment is usually packed together with epidural needle, epidural catheter, loss of resistance needle, 2 syringe, cleaning iodine, drape, lidocaine or for infiltration, water, and a tegaderm or plaster for covering. So these are majority will have this this equipment will be filled with these parameters, but what we need importantly is the epidural needle, epidural catheter, loss of resistance needle. These three are the most important to do epidural, because you can get those other equipments from your areas. Okay, so the above three are the most important equipments needed. So coming to the technique is not that much necessary here, but we'll go through rapidly. So once you have identified the interspinous process, or once you identify the place you insert, depending on your surface landmark, then you infiltrate with local anesthetic, then epidural needle will be inserted. Okay. Inserted, then gradually with loss of resistance technique, we usually advance, and once as you can see from the needle, now the needle is in the interspinous ligament, then slowly with technique of loss of resistance technique, then you will face the ligamentum flavum. Then immediately below the ligamentum flavum is a potential space, the epidural space. Then when you lose your resistance, then that is the exact place to for the epidural space. So we usually inject around 5 to 10 ml of saline to expand the space and treat our epidural catheter. Okay, paramedian is also almost similar. So this technique may not be with discussion easily to understand. Maybe it's difficult, but so once you insert your epidural catheter, you need to advance around 20 centimeter, and usually we leave 3 to 5 centimeter of epidural catheter inside the epidural space. Okay. So once you have checked for CSF leakage or intravascular insertion with blood on the while aspiration, you have to check for CSF as well as blood so that you can avoid intrathecal as well as intravascular insertion. So for this, we usually use test dose. We give 3 ml of 1.5 lidocaine, 1.5% lidocaine, around 60 milligram of lidocaine with 50 microgram of adrenaline or epinephrine. Then we expect if it is intravascular, there will be an increase in heart rate around 20 to 30 beats per minute, or there is an increase in blood pressure with systolic blood pressure around 50 to 20 millimeter of mercury. If the patient from the baseline, if the patient has those increment in heart rate or blood pressure within 3 to 5 minutes of administration of this test dose, then you will say the catheter is in the artery, or intravascular injection is a possibility. Or if the patient develops motor blockage, then you can say it is intrathecal or in the CSF. So you have to rule out those two possibilities. Intravascular as well as intrathecal should be ruled out. So our target should be in the epidural space. So administration is two-way. One, single shot administration is a possibility. The other is continuous epidural administration is a possibility. But the better one is a single shot administration due to it is simple. The other the distribution is uniform, because when we administer with single shot, we'll administer with pressure. That will result in uniform distribution at the level. So level of analgesia is affected by one, the dose, usually volume multiplied by concentration. We usually do, if you increase the volume, it will have increased level of blockage. So dose volume and the concentration is important for level of analgesia, as well as the site of injection is also important. Okay. So the spread of analgesia vary directly with the age as well as the height. As the height increase, there is a decrease in the level of blockage or level of analgesia, and as the age increase, there is a direct relationship with level of analgesia. It will increase level of analgesia. Okay. The duration of analgesia is usually affected by your local anesthetic as well as the additional drug we are using. So there are different types of local anesthetic used in for epidural anesthesia or analgesia. These are the commonest one: chloroprocaine, lidocaine, bupivacaine, ropivacaine. This lidocaine and the bupivacaine are available in our setup. So lidocaine is fast onset; it will have faster onset, but bupivacaine has a little bit lower onset, maximum of 20 minutes to have analgesia. But in case of lidocaine, 10 to 15 minutes, but even less than 10 minutes can be time of onset. Okay, so ropivacaine is almost similar to bupivacaine, but the cardiac complication is more common with bupivacaine than ropivacaine. So if available, ropivacaine is better than bupivacaine, but in our setup we are using bupivacaine due to its longer duration of action as well as availability, easily available. Bupivacaine is easily available. Okay. So there are different adjuvant or additional drugs that are added to local anesthetic to increase the time of analgesia as well as it will decrease the absorption of those local anesthetics. Especially epinephrine is commonly used, but in pregnant mother it's not commonly used. What is commonly used is opioid. Opioid can be used for epidural as well as spinal, either alone or in combination with local anesthetics. Okay, different opioids can be morphine, can be fentanyl, can be petidine, but the better one is fentanyl because of its decreased side effects to the mother as well as to the fetus. So epidural opioids, it's better to use in combination with local anesthetics because both, if we use alone, we have to increase the dose. If we are going to use opioid alone, we have to increase the dosage. Like if you are going to use morphine, maybe epidural morphine should be around 5 to 7.5 milligram, but usually recommend 5 milligram of morphine. That will have a significant effect on the side effect on the mother as well as the fetus. Okay, respiratory depression is significant. So we have to combine with local anesthetic. If you combine with the local anesthetics, then the dosage will be decreased as well as the side effect will also decrease. So it will have post-operative or post analgesia, post-labor pain or post-CS pain should be decreased with opioids. If we add opioid to our local anesthetics to use during epidural, then it will stay for longer durations. Okay. Anybody? Are you hearing me?
Yes, doctor, we're hearing you, but the time is going a little late for you since you're at the hospital. Can
okay,
we
so I will complete with the next 5 or 10 minutes. 5 minutes at least.
Yeah.
Okay. All right. So yes, the other additive. Yes.
Go ahead. I'm sorry.
All right. The other additive drug is sodium bicarbonate, which is not well usually used widely. So we usually use sodium. We usually use opioid or epinephrine. Okay. So how do we activate epidural in the first stage of labor? So there are different steps, especially once the epidural is inserted at any level, at any time of labor, either it's in latent stage of labor or in active stage of labor or second stage of labor. But if there is epidural already in place, then we have to follow those steps. The first step is, as I've discussed, we have to test our epidural. Is that in the right place or not? No, we have to test, as I've discussed, with 3 ml of local anesthetic, especially lidocaine, due to its fast onset, and adrenaline or epinephrine, 5 mic per ml. So after 5 minutes, if there is no complications, we have to put the patient on supine position, left lateral displacement, and we have to administer 10 ml of either bupivacaine, lidocaine, or whatever you have. You have to administer 10 ml. It can be bupivacaine, for example, bupivacaine 5 ml of 0.06 or 0.0125, because we have to dilute those local anesthetics so that you can avoid motor blockade. Okay, so after we have to administer 5 every 1 to 2 minutes, 5, then see for 20 minutes and assess, monitor for 20 minutes, then assess the level of pain, ask the mother to if there is any pain, then if there is pain again, then repeat the above steps. Okay, so it's not that much a problem. Once we have inserted the epidural, then there is no such a problem. Okay, so as you can see, you can use also a continuous epidural infusion with those concentrations. So so the third option one is the patient controlled epidural analgesia is currently widely used in the Western setups. Okay. So in the second stage of labor, almost it is the same, but here we have to extend our block to, as I have said, S2, S4 should be involved in the second stage of labor. So we have to consider that, and our volume will be increased as well as our follow-up will be increased. We have to increase our monitoring every 1 to 2 minutes, but the other way of administration is almost similar. So when we say failed epidural, it's usually if the block is not done, or if it is unilateral, then we can say the failed epidural. So we have to hurry for due to the time. We have to see some of the side effects, the common side effects or complications of epidural or spinal blockage. So the first one is hypotension. Any systolic blood pressure less than 90 millimeter of mercury during your management or during your epidural management, then that is hypotension. So it is due to sympathetic blockade. So sympathetic blockade will result in peripheral vascular dilation, which will decrease the systemic vascular resistance, as well as the venous return to the heart and the cardiac output will be decreased. So this is the reason. Sympathectomy is the reason to develop hypertension. Okay, so the treatment is peripheral vasodilation. So we have to constrict the peripheral vasodilation. That is the definitive treatment with vasopressors. But supportive head down position and volume resuscitation is also important. But the most important thing is to use vasopressors or peripheral vasoconstrictor, such as phenylephrine and epinephrine are the selective alpha 2 agonists, which will constrict peripheral vasodilatation. So that's the ideal treatment. Okay, bradycardia and asystole can also be there. This is due to blockade of the sympathectomy at the level of T1 to T4. These are the cardio accelerator nerves are located at T1, T4. If our level of blockade is at the level of T1, T4, then the patient will have bradycardia. So the management is ephedrine, atropine, and epinephrine is an option of management if we face bradycardia during our management of epidural analgesia. The other commonest one is post-dural puncture headache. If you suddenly puncture the dura, then the patient will have a leakage because our needle is large. So if the dura is pierced, then the patient will definitely have post-dural puncture headache. But it should be diagnosis by exclusion. We have to exclude other cause of headache during our management, so that we can miss meningitis or different space-occupying lesions. So we have to focus first other cause of headache, then come to post-dural puncture headache. So the manifestation is usually it occurs 12 to 48 hours after epidural or spinal anesthesia and analgesia, and its postural headache usually worsens in sitting position and relieved in supine position, and it's usually occipital or frontal or both at the same time, and it's usually described as a dull and throbbing type of headache. Okay, so there are associated symptoms like nausea, vomiting, anorexia, malaise, and There is also ocular disturbance manifested by diplopia, blurred vision, and photophobia, which is called spots. So if these are present, then we have to say it is a post-dural puncture headache. There are different risk factors. Age is one, young age, female gender, history of previous post-dural puncture headache, size and tip of the needle. As I say, if it is epidural, the epidural needles are usually large in size, as well as cutting type of epidural needles. So these are the risk factors. Repeated puncture or during our insertion, if we repeated puncture, then it's a risk. Pregnancy is also another risk. Treatment, majority of the treatments are conservative, bed rest, IV fluid resuscitation, analgesia with acetaminophen, and the possible caffeine. Caffeine is also said to be helpful. But if it's not relieved by this, then we have to go for blood patch. It's a definitive management for which is done in patient. Blood is taken from the patient, its own blood, and it's administered at the same level that epidural is done, or one level below the epidural is the place where the epidural is done. Because one level below, because the patient is going to be lying flat, so the blood will flow back and cover the level of the injury, or the puncture area should be covered with the blood. Currently, the other way of management is the sphenopalatine block with local anesthetic is non-invasive, and it's almost similar to the blood patch. It relieves pain, it relieves headache with the same level of blood patch, but it's relatively non-invasive. Okay. The other is systemic absorption, and intravascular injection is also another complication, but it will occur with large dose of local anesthetic requirement, and it will result in presence of numerous venous plexus in the epidural space. Because in pregnant mother, the epidural space is very congested, the veins are engorged, so it's a possibility to inject intravascular. So we have to be very cautious, and we have to assess for mild to severe features of intravascular injections, such as restlessness, slurred speech, tinnitus, and perioral numbness should be the first sign and symptoms. Then later on, if it is severe enough, it will result in seizure, unconsciousness, and even cardiovascular collapse. If these things happen, then the ABCDE assessment as well as approach is important. And if the patient is into cardiovascular collapse, then we have to initiate the ACLS guideline and management. Okay. Others uncommon is accidental subarachnoid injection, which will result in injury to the nerve, and it will result in permanent neurologic deficit, but it is not usually common. Okay. And epidural hematoma, neural injury, infection, subdural injections are also a possibility, but they are rare but dangerous complications. How do we follow? We have to monitor in the documents those patients with our basic monitoring system, pulse oximetry, ECG, and non-invasive blood pressure monitoring, and assessing sensory and motor block, as well as evaluating the site of catheter so that we avoid infection at the site. We have to care pressure areas, because these patients may have motor blockade in the pressure areas, which result in bed sore. So we have to focus on that. We have to assess our aim. Our aim is analgesia. We have to assess for analgesia, and troubleshooting during this monitoring should be important to assess. Okay, so these are some of my reference. So please, thank you very much. This is for the day, I think.
Thank you very much, Doctor. So due to the time, we won't be having any Q&A for today. So Doctor, on behalf of Blue Health Ethiopia and all our participants, Thank you very much for the nice presentation, despite having difficulties with the technical issues and the network. Thank you very much again. And we hope we will be having you in the future with other topics as well. We also would love to thank all the participants for their attentiveness and their patience. And Doctor, if you have anything that you want to address at the end, let me give you the stage one more time.
Yeah, thank you very much again for giving me the chance as well as inviting me here. I hope we will meet again for detail other topics. But for today, I think due to different technical issues, we took too much time of our audiences. But as I will thank all of you, the audience, and as well as you guys, the Blue Health Ethiopia. So thank you very much.
Thank you very much, Doctor, and good night.
All right.